Well, hello, and welcome to my case study on pediatric malignancy. So this 5-year-old is brought to the clinic with a 3-week history of fatigue, pallor, which is just the skin looks pale, decreased appetite, and easy bruising. He has previously been healthy with no major medical problems. So the subjective history that the nurse will receive and is looking for, because the nurse is already thinking this looks like it could be a malignancy. Things that the nurse is going to ask about are fever, infections, fatigue, pallor, bleeding or bruising, abdominal pain, nausea or vomiting, bone pain, or headache. These are all signs and symptoms that may show up at the onset of a malignancy. So the physical examination of this child shows a heart rate of 110, a respiratory rate of 26, and a temperature of 104. Do any of these sound concerning? Yes, absolutely. The child has petechiae on his trunk, which is tiny little pinpoint hemorrhages and bruising on his legs. When the RN looks in the pharynx, she notices some big tonsils that are red, erythematous, and they have exudate on them, which looks like an infection, like a strep infection. The nurse has also palpated lymphadenopathy, which is enlarged cervical nodes, which are up here in the neck, which 4 centimeters is pretty big. Many times when kids are just sick and don't have a malignancy, they can have some enlarged lymph nodes, especially because their musculature is not developed, so you may notice it more than you do in adults. But in very enlarged cervical nodes, 4 centimeters is very large. The lungs are clear to auscultation. The cardiovascular status is normal. The heart rate is regular with a normal rhythm and no murmur. The abdomen, the liver, and the spleen are palpable 2 centimeters below the costal margins. So that is hepatosplenomegaly. So that is concerning as well. The nurse notifies the provider and they order a complete blood count, and it shows a hemoglobin of 7, which is low, platelet count of 32,000, which also is low, and a white blood cell count of 13,000, which is high. The more concerning part of the CBC is the amount of blasts. There's 5% blasts noted on the complete blood count. That means those are immature white blood cells. So although that there's a large amount of white blood cells, the infection-fighting cells, they're immature. So they're not able to help fight infection. This is an immediate referral to the pediatric oncologist with these results. Further lab tests that are ordered are a chest x-ray, which is normal, BUN and creatinine, which checks the kidney function, which is normal, and liver enzymes, which are normal. A lumbar puncture is done by the pediatric oncologist. It shows no central nervous system invasion at this point, which is good. A bone marrow aspiration is done, and 95% blasts are noted. So the child does have leukemia. Within the bone marrow aspiration, they are able to determine the type of leukemia. And it is determined that this child has ALL, acute lymphocytic leukemia. Now, acute lymphocytic leukemia is this disease that involves the blood-forming tissues of the bone marrow, the spleen, and the lymph nodes. So specifically, it's distorted and uncontrolled proliferation of the white blood cells. Again, there's a lot of them, but they're abnormal and they're immature. So they are not good at fighting infection. It's a rapidly progressive. The blood cells are not able to function normally. Acute lymphocytic leukemia accounts for 1/3 of all childhood cancers. ALL, or acute lymphocytic leukemia, is the most common form of childhood cancer. It is not the most deadly, though. Brain tumors account for the most cancer-related deaths. The overall cure rate of ALL is over 70%. We do know that the higher the white blood cell count is at diagnosis, the worse the prognosis is. So thinking about hematopoiesis, or how the blood cells are formed, remember that the formation and development of the various blood cells, remember you have 3 different types of blood cells. You have red cells, white cells, and platelets. And they all stem from the stem cell. The process includes the proliferation, differentiation, and maturation of the cells into 2 distinct cell lines, the lymphoid and the myeloid. So that is why we can end up with 2 different types of leukemia, either the acute lymphocytic or the acute myeloid leukemia, AML. AML is the more dangerous type of leukemia. ALL is the more common type, and it has a better prognosis. So remember again in hematopoiesis that the malignant stem cells result in cells that have lost their ability to regulate cell division and to differentiate into mature functional cells. So what happens is immature cells accumulate in the marrow, in the peripheral blood, and in different organs like the spleen and the lymph nodes. So that's why we notice problems there like enlargement. So how do we manage this child with ALL? Well, as I said, it is an immediate referral to the pediatric oncologist. The child gets an implanted central line or port because the child will need chemotherapy. So you're not going to start a new IV every time the child needs chemotherapy. So an implantable port gets put in the chest so they don't have to keep poking with IVs. The child has 3 years of therapy, which includes inpatient chemotherapy and outpatient chemotherapy. Remember that chemotherapy attacks the rapidly changing, differentiating cells. So what you can end up with is a child who has a decrease in all of those cells, red cells, white cells, and platelets. So this is your big pens up for this case study. Make sure you remember the basics. What do red cells do? What do white cells do? What do platelets do? And if the child has a decrease in one of those, you need to make sure to prevent complications from that. Now, we already said that the child with leukemia may have a very high white blood cell count, but that means that the child will have immature white blood cells and will not be able to fight infection. The child also may have a normal white blood cell count or may present with a low white blood cell count, depending on the stage of diagnosis and the age of the child. But thinking of immature white blood cells, make sure to prevent infection. This is another key pens up point. If the child is hospitalized, how are you going to prevent them from getting an infection? Hospitals are where sick people go. There's tons of germs in hospitals. So how are you going to prevent this child who's hospitalized from getting an infection? Well, first of all, we say neutropenic precautions. If a child has an increased risk of infection, people going into that room will need to wear a mask because if they have an infection, they want to prevent the spread of that to the patient. Now, what happens if the patient needs to go off the unit for a test? How are you going to tell everybody in the hospital to put masks on? Well, we do the opposite then. Then we put a mask on the child. The next cell that we have to worry about is the platelets. So if the platelets are low, what are the risks for the child? Well, remember what platelets do. Platelets help prevent bleeding. So if the child has low platelets, they're going to be at increased risk for bleeding and bruising. So we need to be careful about that. If the child has a low red blood cell count, remember that oxygen flows on the red blood cell and the hemoglobin. So when you have a low red blood cell count, you are having anemia and risk for low oxygen and fatigue. So we need to make sure these children rest and receive proper amount of airway control and oxygen if needed. Further management, when a patient is receiving chemotherapy, we know the side effects that can cause, specifically hair loss and nausea, are very significant for children. So number one, we want to try and prevent that nausea as much as we possibly can. So we will be giving an antiemetic before the chemotherapy. Doesn't work very well after. We give it before. And then to help the child with body image, we start preparing before the chemotherapy has started about what they would like to do in anticipation of hair loss. There's cooling caps now that can be used that can decrease the amount of hair loss. We still want to prepare them. Do they want to wear a hat, a love your melon hat? Do they want to wear a scarf? Do they want to get a wig? And help prepare them in that way. So follow-up of this patient. He's been off of chemotherapy now for 3 years. He's been in remission for over 5 years. He visits the clinic every 3 months for follow-up appointments. He has no physical health impairments. He does have some mild learning disabilities in math and language, although there were no neuropsych testing done before the chemotherapy. Chemotherapy may be a likely cause of this learning disability. And in high school, he's playing sports and thriving. Thank you.